Thank you for being with us today. And my name is Dr. Johanna Contreras. I'm the Director of Ambulatory Heart Failure at Mount Sinai Health System, and I'm the Director of Diversity here. And I have the pleasure today to speak with Dr. Piña. Dr. Piña is an amazing person, an amazing mentor of mine, and a wonderful person to work with. She's currently the Professor of Medicine and Quality Improvement Officer of the Cardiovascular Line in Jefferson University. She has done a lot of work in the expertise and working in improving the access and healthcare of Hispanic patients, actually the all minority patients. And I'm gonna have the pleasure to talk to her today about heart failure in Hispanic patients. Hi, Dr. Pena, how are you?
Thank you, Johanna. How very nice to be with you here. Thank you for asking me.
No, thank you. So, Dr. Pena, tell me, let's talk about what you think. What did you choose heart failure as your topic in cardiovascular medicine?
It was interesting. I backed into it by first, I was running the exercise laboratory at the University of Miami, and my chief kept sending me patients who had terrible ejection fractions, and he wanted me to put them on the treadmill. And when I was in training, I had been told that patients with low ejection fractions should never be put on the treadmill and exercise. I didn't know where that came from. So I put them on the treadmill, and I realized they could walk a lot, even when those ejection fractions were so terrible. And so that sent me on the hunt for the exercise physiology of heart failure, which is where my real love is. Um, and doing that, I learned, I said, this is such an interesting syndrome. Nobody wanted to take care of heart failure patients back then. Nobody cared about heart failure. It was something that you knew the patients were going to die. They were weeping through the skin, and sometimes in the morning they would just be dead in bed. And there was nothing we could do. We had no positive trials. We had dig and diuretics. Um, and I think it was backing into it through the exercise physiology and understanding the physiology of exercise better, which I still don't have 100%. Um, that brought me into heart failure. And then, once you meet the patients with heart failure, they are wonderful patients. They're very thankful that somebody is actually trying to listen to them. And then we started to get positive trials, and we all said, aha, this is something that we can fix. This is something that we can do better. And we're still doing this. We haven't stopped.
That's amazing. So, talking about Hispanic patients, what do you think our patients are so affected by this disease, um, given its cardiovascular factors and everything that is happening?
I don't think that the prevalence in the Hispanic patients is higher necessarily. I just think that you and I are exposed to populations that have a lot of Hispanics in the population. And so we're seeing a lot more of it. But the risk factors are there. Certainly hypertension, depending upon where they're from, because as you and I know, all Hispanics are not alike. And each country of origin may have totally different genetics. And we know, for example, Puerto Rican patients in New York have very high blood pressure. Well, the Cubans may not. Dominicans may have more coronary disease. So you really have to know what the background of the patient is. So I don't think it's necessarily the prevalence. What worries me, I'll tell you what worries me about the Hispanics is where are they getting the information for the right thing to do and for giving them the right drugs. They're less likely to come to a university center such as yours or such as here, where we have organized heart failure programs, which they can do very well if they enter these programs. They may go to their local, barrio clinical practice where those quality measures may not be in place. Um, and then, us, we call the neighbor, we call our cousin, we call our sister, and that's how we get our medical information. So you have to understand us culturally, and I think we're different.
Exactly. What do you think was one thing that I see in a lot of my patients, you probably see in Hispanic patients, and I see in my own family in Colombia, the preventive medicine is lacking a lot. So a lot of these patients, when they come to us, they come actually very late in the disease process with and give us little options. What do you think the role will be there?
I think you're right, especially things like hypertension. There's still some countries there still think that the blood pressure goes by the age. So that if you're 40, it would be okay for your blood pressure to be 140. Then if you're 60, it's 160. And so the definition of what normal is not well defined in the Hispanic population. I have friends in Miami who still call me and say, "Oh, my blood pressure is so low." I said, "What's low?" It's 100. I said, "Congratulations, that's wonderful," because it's 100, and they think now it's way too low. Um, I had a very unfortunate event. Now it's almost 2 years. One of my very best friends, a veterinarian from Cuba,
Mm.
she was 50, 51, not told me that she had high blood pressure. She had been counseled by her GYN, another physician, orthopedic, that her blood pressure was high. Never told me, never took anything. Was putting her mother to bed, her elderly mother to bed, and she just dropped down.
Wow.
Massive intracerebral bleed right in the center of the brain, and I knew she would never wake up. She lasted a week. This is a woman who was getting an MBA, who owned 3 hospitals, and all of it could have been prevented if she would have taken her blood pressure and, taken the drugs that she was being given. She was given lisinopril. She never filled it. She never took it.
Amazing. So that's amazing, and I think that's the problem that we have. And what you say is right. People get information from the corner office. It's hard for them to believe. What do you think? I know as a medical center, and we have in New York too. Amazing being how segregated people are, and people don't want to leave their own neighborhoods, and it's very hard for them to get access to this big academic medical center like New York, as you saw here.
Oh, the difference. They don't know the difference between the big academic center, and they think that that's something out there that they can't go to. They have to stay in their neighborhood. So I think we need to teach the Hispanic population. They're not going to the American Heart Association lunches for Go Red for Women. They can't afford that. So we need to go where they are. And I'm always thinking, how can we do that? How can we reach the population there where they are? How hard is that to do?
No, I recall. I remember you did the brown bag initiative to check the medicine with patients. I thought it was amazing, and I think that your kid did here in New York City. And you get amazed how many people come to the office and don't have any idea what the medication they are taking, what they are for, if they should be taking them or should not be taking them. And I feel like I know a lot of the community outsources. We need like a dedication from the medical school, I mean, from the educational departments, from people that are in residency and fellowships to get people out there. Do you think this should be something that we should include in our curriculum?
Oh yeah, I think it would be a great thing to start them early, to start to teach them early. The other thing that I found is having the education booklets in Spanish are very helpful, because then you're not going to get them doing an app on the iPhone. But if you give them a booklet, and you write on it and you say, here are your medicines, and this is what I want you to do. And here is we always have had a chart for their weights. When you weigh yourself in the morning, write it down. If you take your blood pressure, write it down, so that when they go into that systematic care, they'll do it. They'll do it, especially if it's in their own language.
Exactly. What do you think about the diversity in the workforce? Unfortunately, as we spoke this past weekend, we yeah we have very few Hispanic, and we have very few people that actually can speak the language and the culture. As you said, sometimes we people go to the nutritionist, they can offer diets that they really cannot follow because they don't have any idea what the foods look like.
Make any difference to them. So I always use the example of hyperkalemia. Bananas have high potassium. Did anybody know that plantains have higher potassium than bananas? Yeah. So you got to tell that to the Hispanic patients who are eating all these plantains. The Puerto Rican patients are making their pastelitos from plantains, not from cornmeal. So, but you're right. We don't have enough of us in the leadership positions in organizations, especially the big organizations, so that patients can see leaders that look like them.
Yeah.
They say patients like me. Well, leaders that look like them.
No, I agree. I'm surprised even here in Mount Sinai we have a lot of Hispanic patients, and they come. They come, and we realize it's difficult to communicate. Patients feel tired. I mean, honestly, as me having grown in Colombia, when I get sick, sometimes it's hard to speak what you really feel in the different language. And you have somebody that is limited in the language, it's very hard for that person to really communicate what they really feel. So, what do you think would be practical solutions that we can apply to get to these patients, to collaborate with associations, to be able to do things like you are doing and you have been doing for a long time with the ACC, American Heart Association? What do you think?
We do a lot in the American Heart. We do a lot of like the TV programs, and we showcase the Go Red for Women in Univision and Galavisión and CNN en Español. However, that's a one-time thing. This has to be a constant sort of immersion of the population. And Hispanics still do watch TV, and they still do listen to the radio. So doing public service announcements like PSAs on the radio and on the TV, I think would be very helpful. For the women, where are the women? They're in the beauty salons. They're not not in the church. You want to get an African American, you can go to the church, and the church is their place of comfort. The Hispanic women are not in the church, but they're in the beauty salon getting their hair and their nails done. So we have to, meet people where they are, which is what the American Heart always says. And having the luncheons isn't the place where they are. That's not what's going to get to them. And every time we survey, particularly the women, the Hispanic women are way behind the Caucasian, and I think even further behind than the African American women to understand about the disease in women. So it's that immersion. It's not it's not out there on TV. It's not out there in the radio. These are one time. If you miss the interview of Univision in the morning, you missed it. That's it.
Yeah, that's actually true. And that women, especially Hispanic women, they don't, I mean, they are amazing caregivers. You always see them with their husband, their kids, their significant others.
Family. It's a family.
Exactly, but their own care is very poor, and they really are the ones that are going to be more affected. And unfortunately, they last longer than the men.
Yeah, but also we saw this during COVID, that the sicker COVID patients were the African American and the Hispanics. They've got all the risk factors, but the access to care is just not there.
I know. It's
Same.
amazing that we had that kind of things. When you see your patients, what are the biggest advice you tell them with that when they have heart failure? What is your like pet talk that you give them?
My goal is to get them to take their medicines. I've stopped hankering about diet because it's very difficult for them to do the diet. So if they can avoid the deli, meats and foods, if they can avoid the can, even now Goya has low sodium, garbanzos and low sodium beans. If they can do that, I don't care about the water, take it out. I want them to take their medicines because it's the medicines that we know that work. And so if I can make their medicine once a day or twice a day, not give them something that's 3 times a day, they'll never do it. Something they can take in the morning and something they can take at night. That's my goal, is to get them there. Everything, and then to get them moving. Don't expect them to go to the gym. They're not going to go to the gym. They're not going to get on the Peloton. Get them walking. Even walking in their own neighborhoods will help. So if I can do those two things, which is called the very targeted intervention, I want them to take their meds.
No, I agree. That's a hard thing. I agree with you with the gym. Hispanic persons are not going to go to the gym. There's not in the culture. But the good thing is they're very social. So if they can find activities they can do socially,
Or a
that would
friend
be
to go out and walk with, a girlfriend, a sister to go out and walk with.
no, that's amazing. And the other thing, clinical trials. You have been participating in many, many clinical trials. It's hard to get Hispanic patients on these trials. I don't think it's hard for people like us because we see a lot of them.
You
What
and
people always talk about the access, but what do you think?
Yeah, but you and I don't have problems getting Hispanic patients in the trial. Look at the guided trial. All the Hispanics were mine from the Bronx. because they already know you, they trust you, which is very important for them. They trust you, and you're embedding your clinical trials into their clinic visit. That's what they love. They don't have to go anywhere else. You can make it easy for them. So, but right now, the Hispanics and heart failure trials, it's 4% average. I just looked at this. And for a population that's about to become 30% of the US population.
That would amaze me because
It
like, it's true they don't have access
is
to.
4%.
What do you think we need to do to fix that?
Well, I think investigators need to be committed. If you are an investigator in an area where you have a lot of Hispanic patients, and maybe they're not coming to the academic medical center, you're going to have to go to the community and get them. You know, how did the Saul trial in the Bronx, for example, get the Hispanics? They knocked on the doors. They went out into the community, literally knocked on the doors to get people to enroll. So we're going to have to go to them. We can't sit back and expect them to come to us.
I know. And I think what you said this weekend, like, it's important that we have investigators, Hispanic investigators that actually can do these trials.
And encourage our young people to go into clinical investigation, because it's very rewarding part of what I do. If you put a patient in a trial, they're going to do better anyway, whether they're in the placebo group or they're in the drug group. They're going to do better than the population. They have a coordinator, I call it their extra guardian angel, who they can call, who they can rely on. How many patients have that? Can your patients pick up the phone and call you? No, they can't. But if they're in a clinical trial, they can call the coordinator, who will
That's
pay
true.
to them and talk to them.
No, and that's true. The open line of communication.
Your clinic, same thing. You have that direct contact. They're not going to call you.
No, you're absolutely right. I think there is no communication. There is no way for them to ask questions and get the right information
Absolutely.
to guide us to care. Okay, but this is great. I think thank you so much for joining us today, and we will have a more coming up in the next month. Thank you, Ileana.
Thank you for caring for our people
Thank you.
very strongly about that. Thank you.